So thank you all for coming. And today we're in for a real treat. We're incredibly fortunate to have Eliseo Perez-Stable joining us for our keynote. And as you can imagine, he has a very, very busy schedule, so we're really grateful that he made some time to be with us. Eliseo is, as you know, director of the NIMHD, and has been doing some, I'm sure you have heard about some of the great things he's already been doing with the Institute in the time that he's been there. But before joining NIMHD, he has a long and distinguished career as a clinical and public health researcher, really bridging the two fields, which is so important, especially now when we're seeing this sort of confluence of medicine and public health, with many opportunities, I think, for health disparities research at that intersection. He's recognized as a leader in many areas of research, including tobacco control, cancer prevention, Latino health disparity issues generally, and has also been a very active mentor to many junior folks throughout his career. He's experienced leading centers like this one in several different ways. And he's an elected member of the National Academy of Medicine I'll say it wrong because the name changed. National Academy of Medicine of the National Academy of Sciences. Is that right? Something like that. Okay. And so he's trained as an MD and a clinical researcher, and we're absolutely delighted to have him join us today. So thank you very much for coming.
So good morning, everyone. It's really a pleasure to be here. I have many friends over the years that have been linked to the University of Michigan. Of course, I've known of Anna's work for many years and others here as well. I know John Ayanian is here, and my good friend James Jackson, who I know couldn't be here with us today. But we both had a research center for minority aging research, and I was just sharing with Anna how similar in many ways sort of the buzz that you get from these kind of meetings related to our RICMAR meetings. And I have to also say that over the years in your career, those of you who are still sort of in the early or mid phase of your career, you'll learn that the big meetings, that people want to go to have a certain excitement to them, but these are the kinds of meetings you really learn the most at, sort of the smaller meetings where you're really around people who are different but like you, and then you have a lot more opportunity for interactions. And I think that I've always appreciated those meetings as much as anything else. I want to start by saying a few things about myself. You heard my background as a trainee. Actually, I'm an immigrant. I'll start with that. I'm from Cuba originally. That's where I was born. I came to the U.S. With my family in the early 60s. Learned English in Pittsburgh, Pennsylvania, and then spent formative years in Miami, where I went to high school, college, and medical school before moving to San Francisco. I was always legal. I was technically a refugee before that became a big issue. But English is my second language. That's always my excuse when I don't know something. Well, I trained in primary care internal medicine, and I have a passion for that discipline. I gave up patient care when I moved to NIH, but for 37 years I followed a panel of patients as a general internist, and I know that physicians in this room are the minority, a small minority, but it's really an important central part of how I think about the research that we do. I did training in fellowship and had a R01 in tobacco control when I was 33. I was sort of being in the right place at the right time in the mid-'80s when NIH was just beginning to do that kind of thing. And you heard from Anna some of the things that I've been involved with. Moved to being professor and division chief to being an institute director. And now I've been at NIH for almost 20 months. It's exciting, and I think it's an opportunity to really influence the field in a way, hopefully, that will leave a time for the future to continue to get better. Many of you, our history, I think, just to go through it quickly, in 1990, through Dr. Louis Sullivan, who was at that time Secretary of Health and Human Services, establishes an office within the Office of the Director, so within the NIH Director's Office, the Office of Minority Health Activities, I think it was called. It was changed to Minority Health Research before the end of President Bush's term. And then in the year 2000, through legislation championed by Representative Louis Stokes, who actually passed away a couple of years ago, it was moved to become a center. And that was probably the critical transition. It went from an office to a center. So at NIH, that means you have a budget, you give grants, it gives you some authority over a certain area. As an office, what you could do is basically collaborate with other institutes, such as the Office of Women's Health or the Office of Behavioral and Social Behavioral Research that continues to exist at NIH, to give you examples, and other recent ones that have been established. Then as part of the Affordable Care Act in 2010, and legislation that was championed by Senator Ben Cardin and the Congressional Black Caucus, and actually I think Senator Kennedy was very involved, although he was too sick at the end to be actively involved in the passing of the legislation, which occurred just a little in early 2010. We became an institute. And so we were elevated to an institute. The language that did that also establishes offices of minority health at each of the federal agencies in the Department of Health and Human Services. So the CDC, FDA, HRSA, SAMHSA, HRQ, all of them have offices of minority health, all coordinated by the director of the Office of Minority Health, which was Nadine Gracia under the Obama administration. Currently there's an acting director, Carol Jimenez, and we'll see when that appointment comes. But we actually get together, we talk, usually once a month there's an effort to do a phone call, and there's a Disparities Council within HHS. All of it sort of stimulated by the ACA, but clearly has momentum, and also CMS has a representative, all great people. And then John Ruffin was the director of all these entities until he retired in March of 2014. Yvonne Maddox was acting for a little less than a year and a half, and then I started in September of 2015. With the boost in budget of 2016, we were about $280 million. This year we're on a continuing resolution, so we're still in that ballpark, and we shall see what the process leads to for fiscal 18. So our mission really is to support research that advances understanding and improvement of health and disease in minority, racial, ethnic groups in the U.S. That's part of our mission. Our second part is to support research to understand the causes of and define mechanisms leading to interventions that reduce health disparities. A lot of this is my own wordsmithing of, you're not going to find these exact words on our website, not yet anyway. So it's really two tiers. So one, we have minorities, all the minorities in the U.S., and we'll go over that. And then the other is health disparities, so things that are worse for disadvantaged groups, and I'll go through that. We don't really have a training budgets per se. We have a very small allocation to training, but we are very committed to working with other institutes, and now with Hannah Valentine, who's the Chief Diversity Officer, to promote diversity in the biomedical workforce, and I'll talk about that as well. So minority health definition, an operational definition, focuses on everything, all the health determinants that lead to specific outcomes within a minority group, either in comparison to others, to whites, or within themselves. And this is anything related to whether it be behaviors, attitudes, biology, clinical care, etc. Race and ethnic minorities, we believe, share a common ground of social disadvantage that is frequently driven in large part in some cases, smaller in others, by being subject to discrimination. And we believe this is true across all minority groups in the U.S. Of course, it's not the same for all minorities. The genocidal history of the American Indian communities is something that is unique. The legacy of slavery in the U.S. is unique, but clearly all groups have been subject to some variation of discrimination. Now, you're all familiar with the Office of Management and Budget. They define the U.S. Census. These are the categories we have, and this is what we abide by. And one thing I would encourage everyone to do the same thing, because that way we collect data the same way, and whether you like it or not. So we're African American or Black. The census, to give them credit, did listen in the 1990s and became more flexible. It used to be this way or no other way, but now they're more flexible with terminology at least. The Asian group is particularly problematic, over 20 countries. South Asians are included there, so people from India and Pakistan, which are technically very different from people from East Asia. And so this is not something that's going to be solved in the near future. They haven't proposed it as an issue, even though many of us have brought it up with them. American Indian and Alaska Native, a small group but very important. Native Hawaiian and other Pacific Islander, also a very small group and different from Asian. So we frequently, unfortunately, still see data lumped together, Asian and Pacific Islander, and that is wrong. And we should really proactively try to avoid that, even though I'll show you data today that lumps them, because that's what the way CDC does it still for some groups. And then Latino or Hispanic, about 20 countries, the only recognized ethnicity currently, and of course can be from any race, racial group. And so the census has proposed, and they just recently had a report, a sort of a status report on their proposed changes. Someone sent me the report. It's very tedious and technical. I didn't go through it in detail. Last fall they had an invitation for comment on 4 questions. The 2 that were most relevant was they wanted to add a Middle Eastern North African ethnic group to the 2020 census. Currently, Middle Easterns, North Africans are classified as white because technically as a racial group in terms of the geographic origin of human social groups, they are white. And yet culturally, of course, it's different. So this would be another ethnicity, so that's an interesting approach. And I think it's a good one, a good proposal from the part of the census. Whether it gets approved or not, I don't know. The other thing they wanted to do was to go back to a single question. So no longer ask, are you Latino, Hispanic, yes, no, and if you say yes, then they ask you still what your race is. About 40% of Latinos responded to that question incorrectly. So they would say, yes, I'm Latino, and then when they ask their race, they go, I already told you, I'm Latino. And so their answer would be other. And so this was consistently problematic and missed the intent of the question, was to do a better capture of the Latinos. And I think instead they are not able to get the race of the Latinos who do respond. Now it could be that many of them don't identify with any race. They just say, oh, I'm not any race, I'm mixed. But I think that's a very small number of the Latinos who have that level of awareness, and most of them are just basically saying, I already said I'm Latino, so why should I be another race? And not recognize that about 50% of Latinos say they're white. So there's some risks, some downside of having it as a single question. We always use the single question in California, so I have no problem with that. But there are some issues about, well, will you miss some Black Latinos who will not identify one way or the other? You know, so there are some downside to it, but it's not, I think it will be better in my view as well. And then they had a couple other items that were less interesting on their questions. Health disparity populations for us are mandated, also defined by Congress. So racial, ethnic minorities, all the minorities defined by OMB. So you can see why for us it's important to have that information and to use that as our guide. Second is people of less privileged socioeconomic status, poor people. And this definition is, you know, whether you use poverty level, first in your family go to college. I think operationally frequently we use education as our metric, or some combination of those factors. Underserved rural residents, which for the most part are people who are minority or poor, but I think there is some specific factors in isolation of rural communities that are relevant, particularly in the very remote areas. In listening to people from Canada talk about Northern Canada or Alaska, or also in the United States. And then we recently declared that sexual gender minorities were a disparity population. This was last October. It took about, I don't know, 5 years of process that the NIH went through. It's only relevant to NIH, so for research purposes. It went through a lot of review and approval at the Department of Health and Human Services. And I think the main selling point, because there are not enough data available on a national level to say, well, this many conditions are worse or that condition. There are no really good national data. They're just beginning to have data from NHIS and Haynes, or NHIS actually, basically in Behavioral Risk Factors Survey, they have asked about gender identity and sexual orientation. And you may have seen some of these earlier reports. It's on the basis of discrimination, that folks who we call LGBT plus, LGBTQ, whatever, NIH we call sexual gender minorities, have been systematically discriminated in society in a way that's not dissimilar from minority groups. And therefore, that's how we, I think, were able to persuade HHS that this was a good thing to do. I'm empowered to make this declaration as director of NIMHD in collaboration with the director of HRQ per the legislation. Of course, I don't think the director of NIH would just want me to decide on my own, and so it had to get full buy-in from leadership, and they did. So these are the disparity populations, and then we look at poor health outcomes that are attributed to this social disadvantage, of which is in part driven by this discrimination issue as well as being underserved in healthcare. So to have a disparity, a health disparity, you had to have a worse outcome in a disadvantaged population. So the fact that white men have more heart attacks is not a health disparity, just to put it in that perspective. And I kind of repeat the same thing here. Our research then is really dedicated to advancing the knowledge about mechanisms and how the different health determinants affect disparities, and then using this knowledge to develop interventions to reduce the disparities. Most of us, I want to speak generally here, inclusive, come from backgrounds where we're eager to do something about what we see as injustice or wrong or a difference. Sometimes we can't make it go away because of factors that lead to those disparities. And sometimes if we don't know where to do the intervention, if we don't understand the factors that lead to the outcome, we're really spinning our wheels in doing interventions, and we don't need interventions that don't work. And so I encourage people in the field to really focus on mechanisms and etiologies and know what buttons we need to push before we start pushing buttons. Now, in thinking about what are the outcomes that we're looking at, I want to be simple and look at things that we can compare in any population. So it's easy enough to say, well, the incidence is higher, the prevalence is higher. Okay, we compare that. Some measure of burden of disease and disability-adjusted life years has been used a lot in global health. I think it's a good measure. There are half a dozen that are generated from public health scientists that CDC uses and publishes on this. Quality-adjusted life years before age 65, to look at premature mortality, for example, is another one. And then excessive mortality or premature mortality in particular, in areas where populations differ. And the fourth bullet focuses on anything and everything that people or patients, putting on my clinical hat, report, that is in a standardized measure. So after all, we're in the business to make people feel better, not just live longer or have less disease. So want them to feel better. So things that are symptom-driven metrics that have been developed and validated and reliable are good. Health-related quality of life, activities of daily living, these kinds of measures are good outcomes to focus on as well in our patients, in our participants, as long as the measures are good. I think that's the important part of it. So just a laundry list of some of the mechanisms that we believe are causing health disparities, all of you have worked on. Most of the emphasis, I think, has been in this individual behavior lifestyle area. This is where I started, smoking, screening, what led people to believe that whether they had gout cancer or not. But this has now been extended to a lot of issues around response to stress, conceptualizing racism or discrimination as a form of chronic stress, seeing how that responds, how you get biological responses to that, and what does that cumulative effect lead to chronic disease. for example. A variety of factors, whether it be adverse childhood experiences, food security, being witness to trauma, whether it be from the literature we've seen from conflict zones to areas of growing up in poverty. And then immigrant stress is another topic, or being an immigrant and then not being able to speak the language, the dominant language in the culture you're in. What's happened in the last 20 years in the area of basic science and biology, and since many of us come from more of a population science, public health, or clinical science, is really amazing. And we need to stay connected to that and tune into that and incorporate that as appropriate in the research that we're doing. It's not just the Human Genome Project and epigenetics, but it's also metabolic differences that have been identified, different pathways that lead to chronic disease over a course of 20 or 30 years, not necessarily that something that you'll see in short term. Being more susceptible, whether gene environmental interactions that then lead to susceptibility, faster progression, and more severe manifestations. And a variety of metrics have been worked, so stay connected to this. You need the multidisciplinary approach in order to address what we're about. And the health disparities is not a simple, it's not one science. It's really, we have to draw from all other groups. In a similar parallel way, much less well recognized at NIH, has been the explosion of information about the importance of the physical environment. If you track the literature on place, on what the influence of neighborhood is, it really took off in the 1990s, late 1990s, and has exploded in a very parallel way to what's going on with some of the areas of basic science that we hear a lot about. And the importance of, where the social system, the place, the type of neighborhood, safety, infrastructure, green areas in urban centers, et cetera. So all of this is a critical. Just 10 more minutes?
No, I think we have more time.
All right.
Oh, I'm sorry. I'm like a whole hour off.
Yes.
My bad.
I want to leave time for conversation. The cultural environment is around family, social interactions. Again, we need to capture what's good about talking to people, or what's good about a community cohesion. People talk about social capital. Is it good to know your neighbors? Is it good to know who lives next to you? Do you talk to people? And I'm not referring just to the digitalization of interactions now, but there is a power to that we haven't really ever figured out what is it about it, the social support that makes people live longer or have better outcomes. And I think there's probably a scientific pathway or a biological pathway that helps understand that, and being able to capture that and promote that. We've known for 40 years that if a man has a heart attack, not just what we now know about statins and aspirin and blood pressure and smoking, but if they actually were married, they lived longer after a heart attack. And there was only men that were studied, of course, and so I think that's an area I think that needs to. And then the other is the clinical environment. At the NIH, clinical research is primarily focused on clinical trials and observational cohort studies. There are areas of NIH that do health services research, particularly in NCI, NIA, child health some. There are pockets of activities of this type. But being a general internist and coming out of a clinical setting, an ambulatory care setting, longitudinal care, I think the healthcare setting is a tremendously important laboratory where disparities may be generated or addressed and reduced and studied, and for sure studied. And I think this is an area where we need to bring in our public health and social scientists, as well as the biological components that are relevant here. So with help from led by our scientific staff at NIMHD, they borrowed a paper that I did with Carl Hill and Marie Bernard and Norman Kaplan at NIA when I was on council. We published a couple years ago and say, well, what's a framework for us to think about? And this is not intended to be causal pathway, just a framework to lay out all the components. And it's a way for us to explain to other scientists what we do and how, what fits into different components. It's up on our website now, linked to the recent funding opportunity announcement on the centers. It was lagged a little bit, but it should be up there now. And so to get the biological, behavioral, environmental, as well as healthcare system components, individual, interpersonal, community, and societal. These are not comprehensive, they're just headlines. There's a lot more underneath each box, of course, and it's just to give people an idea. And you, as new investigators, young investigators, have to say, where is your research on this framework? And you say, well, I'm in this box or in that box, and that helps guide you where you fit into the big picture. Doesn't mean you never cross over into other boxes. You do want to collaborate with people, especially as you evolve, but you often have to start with in-depth research in one area. And then as you develop expertise and accomplish things, then you begin to expand. And that's the way the science moves forward. A couple other comments before I present some data. So the inclusion of diverse participants, I know Monica tomorrow is going to talk about this. NIH right now reports that about 30%, I don't think this is public, but I've seen the presentations and maybe she'll talk about it, of all clinical studies at NIH over about the last 5 years are from minorities. These are domestic studies, so they're not international studies that are distorting this. But we think we have a ways to go still. It's still a little bit of messy data collection. And we now have the systems to be able to do this better. So this is an important area that we need to continue to push and promote. Inclusion of minorities in clinical studies is important, and it is separate from research. Some people have confused, well, if I have a study with lots of minorities, it's minority health research, right? I say, well, maybe. If you're really asking a question that is relevant to that, or maybe you're just having a diverse sample. Now, someone does a hypertension study and they stratify their sample so that they have just as many African Americans as they do whites with questions that are related to that. That's clearly minority health research. But normally, if you're just having a clinical research study, you're aiming to have diverse participants, and you're not necessarily powering the study to be able to tell differences by race, because that makes it almost impossible then to do any of these studies. But if there's something big going on and you have nobody from that group, then you're never going to know because you don't ask, you don't have the people. But if something big is going on, you have some people, you'll probably be able to tell if something is going on. So this is, I think, the fine line that we try to do. It is not just social justice, but it's good science. And there are, I think, a number of examples that highlight this that we could discuss we could talk about in the discussion, or maybe ask. You can talk with Monica tomorrow. We have to be at the table as researchers and as participants. If not, you're on the menu. So we got to do it. It is harder to recruit minorities, and I think what happens a lot of times with investigators is they have this idea where, people put in a table, right, when they submit their grant. In 4 years at NIA's council, I never saw a grant get an unacceptable for their inclusion. Never. It's become like a checkbox that people, investigators, they know what to do, they put in a table, and they say, this is what we're going to do, and that's it. Nobody ever questions it. There is no accountability on the part of NIH, or for that matter, on the PIs. And whether they actually do what they said they were going to do, we're just now beginning to be able to look at that with the information systems we have as they finish their study. So there's a lot to be done here just to get good data to be able to know what to do. But a lot of times people will say, well, I really wanted to get more minorities in my study, but they didn't know how to do it. It was harder. They don't really know how to communicate to that group. So what happens is everything takes longer than you think. It takes a while to start going. Once you get recruitment, you just get recruitment. You want your sample size to be there. So you forget about this. I was going to have 30% non-whites in my study, and people leave that by the wayside. So I think this is really important. It does take more resources and different skills. We don't have any reward mechanisms in place for people who do a really great job of this, if it's not focused on one group or another. I don't think there's a good science of what are everybody wants to know, well, what works? Tell us what works. And I don't think empirically people have been able to show, you know, this works, that doesn't, that works, this. Everyone has stories. One generality is that it takes more face time and more personal messages to get minorities into studies. Language issues are obvious. We think minority scientists are generally better at it, but again, there's no empirical evidence to support that I'm aware, that I'm familiar with. So if anybody wants to ever do that, that'd be great. And we really also need more granularity on the data that we collect. And I'm trying to see if we push that. We at least need some measure of socioeconomic status, and the simple one to ask is just years of education. We could actually do imputed data if they got zip code, but that may be more invasive. Birthplace would be good. They do domestic and foreign, but they don't really know where the domestic participants are born. And with a significant number of immigrants in the US, I think that's a significant thing to know. And of course, language would be another one. And anyway, end this myth that the barriers are insurmountable. I think that's important message. Now, workforce diversity is actually a much bigger problem. And this has really reached the point of a crisis in the profession. On the clinical side, we can see that this is the data from 2014 in medical school graduates, 5% Latino, 6% African American. American Indians and Pacific Islanders barely register. So we're about 12%. And about 40% of US now is of a minority group. So there's a big gap there. But in the scientific workforce, it's even worse. In terms of PIs or faculty, only about 5, maybe 7% of all NIHR1 grants are awarded to African American or Latinos. There's some evidence about bias for African Americans. This is a Ginter paper in Science. That analysis has been replicated internally using complete data, much better systems. Unclear why. Thoughts about review bias is one of the concerns. There's also data that minorities are less likely to resubmit. So you submit a grant, it gets scored, but you don't get funded. African American PIs are half as likely to resubmit that grant. So that's a fixable problem, right? Because you resubmit, your chances go from 12% to 35%, assuming our budget doesn't get drastically reduced. And that's an average, just on average, you're more likely, and yet blacks are less likely to do it. So why is that? So Hannah is working on some interventions to address that. We think mentoring and networking is an issue. There's also data about minorities applying in low success topics. Of course, what are low success topics? Minority health disparities. But other things like hypertension, kidney disease, anything related to community is in there. So it's not so straightforward. And there are good data now that, at least I've been told, I haven't actually reviewed this myself, that PhD, graduate students and PhD graduates, it's not the pipeline issue anymore. We can't say, well, there's not enough people in the pipeline. That's still a problem. We still need to get more, make sure those pipelines continue to come through and get the high school graduates and college students into science and get them to go to PhD programs. But there are people there. So the barrier now is getting to faculty position, getting to be a researcher, be an investigator. So I think this is a challenge for all of us, really. And people at NIH are very much concerned with this, and Dr. Collins did bring Hannah Valentine to be our Chief Diversity Officer, and I think that has made a big impact across the NIH with Institute directors. So what are our priorities at NIMHD? So focus on science and really getting a good handle on definition of what our science is about. This is needed not just for the field and for you, but also internally for NIH as an agency, as an institute. I need to make sure that we are there as equals. Now the directors are all welcoming, but the history at NIMHD hasn't been that. We're relatively new. There hasn't been as much of a focus on the science. And people say, well, what is your science? Don't we do that too? And so I think this is the transition that I have tried to focus on. I think we've made a lot of progress, and some of you have been very helpful in that. So we're moving in the right direction in that regards. Second is that I really want the extramural scientists to come to NIMHD with their best work. So we want R01 applications to come to NIMHD. Until Yvonne Mannix got there, we were not open to the parent application process. We are now. We get about, in calendar 16, we would get about maybe, I don't know, something between 50 to 70 R01s assigned to us at NIMHD. There would be about 40% or so would be scored, and we would look at those. So we should probably get closer to 200 per cycle to be more in par with what other institutes get based on our budget compared to their budget. And these are unsolicited investigator-initiated R1s. If we put out a program announcement, that's separate. And we are doing that in order to stimulate the community. So we're really looking for that. We also are looking to collaborate with others. We have a number of ones that I'll show you a couple of examples. Institutes come up. This goes on all the time at NIH. So programs talk to each other. They have a concept we're developing, and then once we flush the concept through, we say, well, who else might be interested? And we'll get people from other institutes to sign on. Similarly, they approach us about interest in areas that we may be. For example, NIA or nursing, I think, has a funding opportunity announcement sort of percolating through the system on palliative care, on end-of-life care. And NIA, of course, signed up, and we got it, and there were 2 words about minority health or health disparities in each of their areas. So we added a whole section and said, we're interested and here's why. Because essentially that's a very understudied field for minorities, minority health in particular, and health disparities. And then we want really to promote diversity in the workforce within our abilities. We have a loan repayment program. I won't show you the data today, but if we give out about, I don't know, 120 or so loan repayment grants every year, about 50 to 60% are to underrepresented minorities. We can't call for that. That's not by design. That's just really who applies to us. For health disparities research, we have a smaller program for socioeconomically disadvantaged scientists of any flavor, so including basic scientists. And again, the majority of those are minorities as well. Our scientific programs, our extramural program has been operating under these 3 functional branches to try and capture what we are about. Clinical and health services research is new. We now have hired new program staff, so that it's going to build up. The integrative biological and behavioral sciences, so sort of more mechanistic and ideological, but combining both biology and behavior in the same group, the same branch. And then building on our track record in community-based participatory research, community health, and then adding the emphasis on population health sciences with public health science component. So going forward, I hope to be able to reorganize the Institute into these 3 categories, have 3 divisions of this type. It's a long process to get there and complicated, so I won't bore you with those kind of details. And it may not be entirely feasible to do. We may have to do some variation of it, but I think this is the direction we need to move in and be more like other institutes that organize this way along thematic areas of research in their science. These are examples of some of the funding opportunity announcements that either we have published or have cleared through council. HIV is an important area that we are, there's a whole emphasis on AIDS funding at NIH that came out of the epidemic in the early 90s. And this one actually, we got disappointingly few applications. So if you're interested, and it's still open for 2 more years. So HIV-infected youth and young adults from health disparity populations. So only about 10% of these young people, and youth and young adults means adolescents to 25 or so. So the extended adolescents are virally suppressed, and this is just unacceptable that we have that kind of in this day and age. We had one out on immigrant populations. We got more response to that in the first round. It's broken into two parts, etiology and interventions. We had one on disparities in surgical care that actually came out of the surgeons wanting something related to surgical outcomes. And I haven't seen the results of the applications to that RFA. We had one on social epigenomics, again, more mechanistic, combining biological factors with health disparities. We have one that's still in the process of building support, Caribbean initiative. We've had a Caribbean effort. It was a U mechanism, and there were 2 grants that we funded through that. We want to fund at least 3 kind of R1 studies. We have, I think aging is going to join us, and I'm trying to see if heart, lung, and blood will join us as well. It won't be set aside, but we'll probably fund at least 3, maybe 5 or 6 R1 type grants. The idea is to have cohort studies in the Caribbean area that then can be compared to things like the Jackson Heart Study or the Soul Study or other such cohort studies here. Or in the case of aging, the Health and Retirement Survey, which is actually also housed here in Michigan. Hopefully this will get through the current environment. We'll put this up for review as well. It's been cleared at our council. We have one on sleep disparities that should be published soon. This is NHLBI is also collaborating on this. The importance of sleep as a mechanism is really interesting. You always think, oh, I don't get enough sleep. Oh, people would boast sometimes, I only slept 4 hours. It's bad for you. And now there's data about the brain getting washed when you're asleep, so you kind of avoid the senescence that we all get accustomed to as we age. You just function better when you get a certain amount of sleep. And so it's quantity and quality. What does that do to how you function? What does it do to chronic disease? We don't know. There's some association data on this, and so we wanted to give this a minority health disparities lens and see if we could stimulate investigators to focus on this. And it's not about sleep apnea or narcolepsy. It's not the clinical entities. It's really more the public, the population science perspective. We published one on chronic liver disease and liver cancer that came out of a process with NCI that I think was very good, and alcohol also joined this as well. The liver cancer, it's not a top cancer, but it's in the top 5. It disproportionately affects men. Everybody knows hepatitis B and Asians, but actually Latinos and African Americans also have excess liver cancer, and American Indians, and it's not B. It's not hepatitis B that's causing it. Some of it is B or C, but it's not the main explanation. Is it fat? Is it bad fat in the liver? We don't know, and I think it's a good template to look at mechanisms as well as the spectrum of clinical care. I mean, liver cancer is more treatable now than it used to be, and we don't know anything about disparities in that. And then we have one that we just cleared in February on research with the tribal epidemiology centers. This will be working with the Indian Health Service CDC-funded epicenters across the country. There's 12. We provide some infrastructure support for them at NIMHD, but we also want to stimulate them to do research, and this will be an opportunity for them to do that, partnering hopefully if they need to with researchers at other places, and then to use the data that they're collecting in their area. We've had workshops. Some of you participated in the visioning workshop, but these are thematic workshops. We had one on self-identified race, ethnicity, and genomic and biomedical research in October that we partnered with Genome on. Essentially, self-identified race, ethnicity is outstanding, supported by the genetic data. But what's the future going to bring? And this is, I think, an area that we had a great group of people discussing this. And we have 2 coming up in May. One on information technologies and minority health and health disparities is scheduled for May 11th and 12th. And I believe May 22nd is the date for the structural racism. I call it cultural competence from my clinical perspective. They're calling it more, they're calling it something else. Cultural, structural, something related to, I tried to give it as a opposite of each other. And it comes out of my idea. This one I think is we need it, the technology. This one is more like, is this a research construct that we can operationalize? We all kind of accept it as something like that, but how do you actually incorporate that in our studies? And when this first came up at the Institute, I said, I don't know if it is. And then I realized it was parallel to what 10 years ago, cultural competence, is it a research construct? Can I do a measure that measures cultural competence? And I was convinced by colleagues then that it was a systems construct, that you couldn't really measure it the way we measure, language ability or socioeconomic status or food insecurity. But I don't know if that's the answer. So I thought at NIH, you can sort of say, oh, put some money in and we'll bring smart people in. And usually when NIH calls, people say yes. And Office of Minority Health is partnering with us on this. A plug for our Health Disparities Research Institute, like this. This is a competitive application. I don't know if you can see the photo well, but we had 51 scholars. This was what used to be the course, but when I got to NIMHD, they said, we have a course, and I said, I don't want to do the course. I think the institution's got to teach the course. Well, let's bring people here to develop them. And so this is 1 week. We support travel. It's in mid-August, so it's a lovely time to be in Bethesda. Indoors. And the idea is that we give a week of exposure to NIH, so selected topics, lectures in the morning. This is Stephen Thomas, I think, here, and then Nancy Krieger spoke the first day. I did as well. And then the afternoon is more interactive discussions with program officers. We have a mock review session that was very sobering and very popular. People really liked it, appreciated it. Multidisciplinary, we had about out of the 51, there were, I think, 12 physicians, 5 nurses, even a pharmacist, the rest of PhDs of different flavors. So I think it was great. And you can't really tell, but most of the applicants, most of the scholars are minorities. And this is, of course, not by, we can't select on that basis at all. So it's just who we're attracting. We had about 500 applications. So the applications will be open sometime soon. I think the target group here is postdocs and junior faculty. And so the idea is to build capacity. And so send people or come if you think you would enjoy it. Let me spend a few minutes on data. How much do I have? All right. So I'm switching gears now. No longer NIMHD. I'll take you through some population health data that I think have been relevant, that I've been emphasizing in recent months. So this is data from the census, relative risk of all-cause mortality by household income. So if you're poor, you have 3 times the chances of dying than if you make over $115,000. Now, I think this was the upper limit of the tax break that the American Health Care Act was going to get, any kind of tax support. So I don't think it's data-driven in their proposed bill, but you can see it's supported by data in terms of what happens. And you can see sort of flattening over here around 80,000. Median income in the US is about 50. So you're getting a double. So very potent, persuasive influence of socioeconomic status on health. The ultimate outcome, which is mortality. This is related. Saeed Ibrahim sent this to me. It doesn't correlate with mortality, and it's harder to collect, but what's wealth? As you good social population scientists, you know, income is relative. You're first in your family to go to college. You're still making a lot of money, not the same thing as the 3rd-generation homeowner in San Francisco, where property prices double every decade, just about. So you see net worth here for whites, a big dip in '09 from the Great Recession. Look at Hispanics and blacks. And this is obviously another version of this. These are not published yet, but I don't think. Elizabeth Arias presented this at one of our meetings, National Center for Health Statistics data on life expectancy in 2014. A lot of news came out about whites and the decreased life expectancy. Just to reiterate that all of this is poor people. So it's poor whites who have lost years of life expectancy, not middle class or upper middle class or richer whites. So the loss in life expectancy in whites is all a socioeconomic status issue. It's not a race issue. And the causes of it, I think, are important to emphasize. For African Americans, actually, the life expectancy gain in the last 15 years has exceeded all predictors. So rather than the predictive model was about 2% per year increase if things were going well, they've actually been double that. There's still a gap. There's still a big gap here, particularly for men, but also you can see one for women. But it's good. We're making good progress in this regards. So it has continued to improve as mortality has decreased. And then Latinos, you know, nobody can explain it. So this is now the second time the CDC publishes life expectancy data showing that Latino women live the longest. If they ever get their act together on Asian women, that might not last. Asian women may actually live longer, but that's not, they don't have national data on that to release yet. And so they're very convinced, you know, this is a real finding. This is not a data problem. And you can see for men also that they have the longest life expectancy. Now the
Subgroups within Latinos?
they haven't released life expectancy by the subpopulations, right? No, they haven't. They're very conservative statisticians at CDC. It took them over 10 years to release the first set of life expectancy in 2006, even though they had the data for 10 years. And they took them that long to convince themselves that it was okay. It's actually National Center for Health Statistics in Hyattsville. And then this American Indian data is not also public. It's not true national data. It's more grouping regional. This is American Indian, Alaska Native, and Native Hawaiian. And it's really horrible. You know, they're worse than African Americans, both for men and women, by a factor of 4 years. So this is a very this is a high level health disparity group that I think we really haven't done enough on. It's hard because they're in regions, they're in under-resourced regions, they're very rural, or they're very diluted in urban areas. When California has the largest number of American Indians in the country, but they're not easy to localize. You have to really go out of your way to find them. So I think this is partly good news. So this study I think most of you are familiar with. This is the economist view of the world. Dr. Chetty from Stanford and the group published a little over a year ago, or a little less than a year ago online. Very good approach, looking at tax records for pre-tax income and then looking at the death registry, the Social Security death registry. The richest versus the poorest, 1%, you see the gap, the numbers. Remember, 10 years for women, 14.5 years for men. So this is comparing the two extremes. And this is the gap, and this inequality gap has not gotten better. And in fact, they present data that it actually may have gotten somewhat worse over the last 30 years, slightly worse. But remember, you're comparing the worst to the best. And so, not new information. We've known this has been a factor for a while. It's not good that inequality is not getting better. But it's not, that's not, I think, the most novel part of it. To me, the most important part of this paper was at the bottom, I forget now whether it's quintile or 25% in some areas, live an average of 4.5 years longer than in others. So there are some places that are actually doing a good job of taking care of the most vulnerable 20%. So I'm not going to name places, but Birmingham did a good job, and Manhattan did a good job, and some cities that did not do such a good job is the one that's close to here. And I think it's not a matter of pointing fingers, it's a matter of knowing what is going on. So there is something really important about place and about community, that even the poorest people in some places, the same poor people do better compared to other places. Now, this group, they didn't understand it either. They tried to explain it on the basis of behavioral differences. And I don't buy that argument without getting into the details of the statistical models. But I think this is a critical area to do more research on. Now, this is a mega study with big picture. You don't have to do everything mega. You can do more detailed studies and to look at why we're seeing some of this. I mentioned rural residents. The CDC has now published a couple of papers on rural differences. So the leading causes of death in the US, comparing urban to rural, the most urban to rural areas, and they have higher age-adjusted death rates for all of these: heart disease, cancer, COPD, accidents, and stroke. So this is a real disparity. And again, we have not delved into this with as much detail. And I think it's important to look at this. Trends in premature mortality. This came out actually of the NIH intramural program from NCI. They looked at death certificates from NCHS and census data, and then they created age period cohort models going forward between 1999 and 2014. And because it's, quote, premature mortality, once you hit 65, it's all over. You know, forget it. We don't care whether you live, you know, it's sort of like, it used to be that you were already wasted by the time you got to 65, right? That's why Social Security was genius in the 1930s, because people really reached that age, they were burned out. So it only was a few more years. Right? There were always exceptions. But so premature mortality is modeled on under 65. And what were the data? So for whites, the premature mortality is increased. So rehash of what we heard before from Keaton, I guess, a paper a couple years ago. And American Indians and Alaska Native, where they had data on this, also were increased, and more increased than they were for whites. And the causes were accidental overdose, opioids a big play here, chronic liver disease, cirrhosis, alcohol has a big play there, and suicide. And then women had the most vulnerable, were the most vulnerable of all. If you followed the women at age 30 as a cohort, they had the highest annual increases. There were 2.3% for white women. And for American Indian and Alaska Native women, 4% increase. These were the extremes. So it's a complicated model. You have to look at the paper and the tables and the methods. But the message was whites and American Indians, particularly women, were doing worse. Now, the good side is that for Latinos, blacks, and Asian Pacific Islanders, they grouped them together, there was decline. And much of it was from improvement in HIV mortality, cancer, and heart disease. So this is the good things that are going on. And again, there's lots of good data that over the last 15 years, whatever we have done as a society and a healthcare system, particularly the last 15 years, we've seen improvements at least in these metrics of mortality and life expectancy among African Americans, which had also improved earlier but much slower pace. And so continuing to take a look at that, I think, will be important. So the message, American Indian and Alaska Native still have the highest mortalities. Blacks are still, don't get me wrong, it's not like we're done. They're still really high, but there's progress. And I think that's important, because if you had progress, well, we're doing something right. So we shouldn't be abandoning whatever we're doing right. Suicide, this just came out last week, yeah. So white rates for 1907 to 2008, 2015, 20% increase. This is our age adjusted for 10 and older, 96 to 13, so age adjusted incidence of suicide. For African Americans, you can see it's flat and considerably lower. We've known this for decades. Now, we don't know why, but we've known this for decades. For Asians, the same. This is relatively new information that they're generating national data for Asian Pacific Islanders, again, grouped together. American Indian, Alaska Native, you know, they're even higher than for whites, and they've gone up by a similar ratio, about 20–25%. And for Latinos, very similar to blacks. Again, national data, not subpopulations. This is intriguing. So here's not a disparity. It's actually a lower rate and not a subtle amount, by a huge amount, a factor of 2 to 3, or 2.5. And knowing why African Americans and Latinos do better in this particular area, just to say the common groups, not to mention the other groups in their directions, I think is important, a scientific question to ask. I borrowed this slide from, or adapted this slide from John Ayanian, who's sitting in the back. So what are strategies to help reduce healthcare disparities? I won't go into all these areas in detail by any stretch of the imagination. So one is expanding access. So if we get insurance, we have a place and we have a clinician, we know that it helps explain decrease in disparities in some circumstances. When you have a public health consensus, we don't need more data. We just have to go out and do it, do implementation. And I'll show you a couple examples in that category. And then there are others more in the healthcare setting by coordination of care, systems, navigators, targeting conditions that are particularly complicated. Not everyone needs a coordinator or a care manager, but there are some more vulnerable people with bad disease that really need these kind of resources. And we have to be able to distribute our efforts that way. I think there's encouraging data that good primary care with information system, we call the patient-centered medical home, can help reduce disparities if you are taking care of populations. And then whether performance measurements work or not is an issue. CMS had definitely gone in this direction. We'll see what happens now, whether they'll continue to or not. But there's a real risk here with this, that the most vulnerable people will be left out. And I think we're beginning some active conversations with CMS about developing an equity metric for systems. In California, that didn't happen very often. I mean, everybody took care of poor people. It was part of some level of Medicaid was in almost every system. You know, Kaiser did their own things, different, but but here in the East, I should say, it really isn't that way. I mean, there are systems that never see Medicaid, so their numbers will look better. And if you have a homeless clinic, your numbers are not going to look very good for the kind of metrics that people have been developing to look at, which have mostly been around the preventive task force stuff or quality of care of diabetics, et cetera. So this is an area that needs work and I think is an important area. A couple examples of public health consensus. So, we have bad infant mortality rates in the US compared to other high-income countries, but things have gotten better. And particularly for African Americans and Puerto Ricans, who have the highest rates. Notice the Cuban rate here is 3. It is also around 3.5 in Cuba. So it's an interesting, but you see the numbers are all going in the right direction over a course of a decade. Childhood immunization, we say we'll pay for it. We'll figure out how to pay for it. So what happens? We see no disparity. And in fact, now the disparity is going to upper middle class whites who don't want to get immunized because it's good for their kid to be exposed to the natural viruses. And what happens, we get a measles outbreak, we have a mumps outbreak, we have pertussis outbreaks. They're happening in high middle income communities that are predominantly white. I actually don't know that minorities have negative attitudes towards vaccines. I've been saying they don't, but I don't because I just haven't heard anybody that says that they do. And so this is one of those issues that is interesting to think about. As a side. Blood pressure. This came out of the REGARD study published in JAMA Internal Medicine a few years ago, 2013. So prospective cohort studies showing that if your blood pressure is up 10 millimeters and you happen to be black, your stroke risk was 2.38 adjusted hazard ratio compared to whites. Same blood pressure. So 140 to 159, so what we call stage 1 hypertension. And in middle age, the 45, this is where the most vulnerability is happening for disparities. This is where we lose it. We do bad with children too, but I think in the middle age, we create this vulnerability that leads to the excess morbidity, mortality. Once you get to 65, there seems to be actually an evening effect, and in fact, there's a crossover mortality. There's a whole lot of other factors that get into place. Do we do anything about this? Does anybody recommend that we manage hypertension differently by race? I don't think anybody has. I asked the chair of the U.S. Preventive Task Force. They just published a paper on this question, but there's no empirical analysis of this. And so this is something I think that needs to be done. We look at, this is, I think this is from you, John, or CDC. The prevalence of controlled hypertension among adults by sex, race, and Latino origin. So what do we do with African Americans? They're over here in the lighter blue, or whatever color that is. It's lower. So we not only not do better, we do worse. We have worse control if you're a minority. So 2 times worse, but we do worse control. And we know how to do this. This is the bad thing about it. We know what to do. There are great drugs, they're inexpensive, And we know that if people take even 80% of the time take their drugs, we decrease their morbidity, mortality from hypertension as a risk factor. Kaiser published this analysis in 2013 using a registry, drugs, old drugs, modest goal of less than 140/90, compared to other groups in California. They went from 43% control to 80%. Now you get to 80, that's pretty good. Pushing it up to 90 is harder, but let's say that's a good goal. And then the rest of the groups were around 64%. So a registry, getting performance metrics, having guidelines, open access to the patients to visit their medical assistant, a protocol that they could follow with their clinician to say, well, the blood pressure is this, you'll do that. They could contact their doctor or their clinician, and then having combination pills, so you only take one pill a day. In a closed system where the pharmacy and the cost barriers are diminished. So why don't we need to do this in our federal qualified health centers? We need to do this in our safety net systems. We need to do this in all of our systems to decrease disparities. And maybe think about how we do it differently for African Americans who suffer disproportionately from hypertension. Cancer is a different story. There are some obviously gross biological factors that are playing a role here. Environmental, biological, environmental behavior, biological, all combined. To have African American men have 3 times or 2 to 3 times the rate of prostate cancer compared to other men. People will say, well, I don't know why. It's not access. It's not over-screening. We don't have a good etiological factor for prostate cancer. You know, there's a lot of things been talked about, diet, and but vitamin D has been in the play, still is in play in some places. So this is a vexing question. Lung cancer is even more interesting because actually African Americans smoke less. But yet for the same level of cigarettes exposure, they have higher risk of lung cancer. So what's going on with that? And I think this is, again, an important area that needs to be explored, and so forth. In cancer, these differences are magnified. There's probably more of a genetic component that is understood only in a couple of situations. I mentioned earlier the liver cancer. When I first read this, saw this, I thought, well, it's probably B virus, right? It is for Asians. But for example, for Latinos, the SOUL study showed that hepatitis B chronic exposure to hepatitis B was the same as whites, it's 2%. Now, Puerto Ricans have more C, so that could be part of it, but it's clearly some other etiologic factor causing Latino liver cancer to be almost as high as Asians. And for African Americans, we don't know either what the factors are. Some of it, again, is B and C, but it's not the only explanation. And then for women, the differences in breast cancer, we worked with a group and showed that there was an allele in Latina women, mostly of Mexican Central American origin, that was only present in women with American indigenous background. That's protective for breast cancer. So isn't that great? Isn't that fascinating? Having a gene that's protective for breast cancer. And it's about a 40% reduction in a case control design. So maybe overstated with case control studies, but it's hard to do this any other way. Again, African American women have higher rates of earlier breast cancer that's triple negative. Again, people are searching for why is that, and very active search in that, and so forth. We know cervical cancer is caused mostly by HPV, but you see in the big picture, it's a relatively, although preventable, low rate. Some other snapshots. This is also from CDC. They published data on food and housing security. You can see the rates here do vary by race, ethnicity, lower for Latinos and blacks compared to whites for both food and housing. We knew a lot more about food security in terms of effects on disease, we think, particularly around diabetes and obesity. But housing security, of course, has another factor that if we do standardized measures, maybe it'll be a good way to begin to understand the mechanisms for how that contributes. And again, you see this SES gradient that's fairly linear. So less than high school. GED usually behaves somewhere in between less than high school and high school, but they're grouped together here in college graduate. as what is done. Another bit of sort of good news, also released by the CDC a couple months ago, end-stage renal disease related to diabetes. This is a big ticket. If you get end-stage renal disease, you go on dialysis, and that dialysis, I think, is the #1 ticket on the Medicare budget, or it's up there. It's in the top group as a expenditure. And if you have diabetes that's progressing, we know what we need to do to at least delay. Let's not say we don't really prevent necessarily, but we can really delay. We can turn a 5-year process into a 25-year process. And that's really helpful for the patient and for the society. So what's happened between 1996 and 2013, you can see that whites, although they have the lowest rates, went up some. I'm not sure this is significant, but it is interesting that it went up. It's still the lowest. The big story was American Indian and Alaska Native plummeted by 54%. And this is, again, probably an effect of better care. So this is where getting access and doing what we know what to do, you control blood pressure, you make sure you avoid toxins that will make the renal function worse, and probably the second most important thing is you put them on an ACE inhibitor or a receptor blocker, which helps control their blood pressure but also preserves renal function, a specific class of drugs. And you can see that for other groups, blacks and Latinos in particular, the numbers also improved, although not as much as for American Indians, and they still remain high. So again, on the notion that things are not always moving in the wrong direction. I'll say a few words about racism. Not a topic I have done any real work on in my prior life as an investigator, but I think critical construct to have a good handle on. And David Williams, who used to be here, I think was one of the pioneers in this, and some of you have, I'm sure, used some of these in your research. Most of the work we've done is here, interpersonal. So you ask people, have you been discriminated against, or you ask people, do they discriminate, or you figure out associations. And this is the most common, and there are the metrics, the measures that David and others have developed. Structural, I mentioned before, and it has more to do with history, culture, institutions, codified practices that perpetuate inequality. I'm old enough to remember when I first came to the U.S. that there were different bathrooms in Miami for whites and blacks. And so this kind of, what does that do to your psyche, to the historical trauma? American Indians also have a historical trauma that they live with. And people want to say, oh, we fixed that, it's done. That's the attitude that a lot of people have. And it's not to point fingers or blame it, but we have to acknowledge that this is not something that gets resolved with 40 years of civil rights legislation or having elected an African American president. And then this whole notion of internalized racism, so the people who don't recognize that they have been discriminated against, but yet have internalized this in some way, and this is affecting their health. And how do you even measure that? How do you get to that? Some of it, the anticipatory anxiety that you get from having had bad experiences. You don't say, oh no, I'm good. But then you know that in certain areas your body reacts because you've been in bad situations in those areas. And what does that do to your long-term health? We don't know. So conceptualizing this as a form of chronic stress and then being able to present it and study it in that way, I think is one way. This is an update of the Kaiser Family Foundation survey, which they did about 15 years ago. This is published in 2015, and they asked this question literally, in the past 30 days, were you treated unfairly because of racial or ethnic background, store, work, entertainment place, dealing with police, or getting health care? So there's a global question and then separate. First column is yes to any of them. You can see African Americans, 53% in the past 30 days have felt they have been treated unfairly. And this is not a subtle, infrequent, rare problem. I mean, it's 53% of a representative sample. And in healthcare, it's 12 to 14% for Latinos and blacks. And there's 5 to 15% of whites in these different contexts. So this is real, and this is something that we need to, as scientists, get a good handle on and present it. Lots of different ways to to think about it, the stuff I mentioned before that David helps develop, effect on physical and mental health status of African Americans, and I think James Jackson published his early work, particularly in men and in particular around mental health. Again, conceptualizing it as chronic stress. There's data on physiologic measures like blood pressure or levels of inflammatory markers. This is the kind of work we need to really look at more closely and to be able to build a case. More data on effects on mental health and heart disease, because mental health does link to heart disease, and health behaviors. So if you're discriminated against, you're more likely to use substances, smoke, have problem, alcohol consumption. And then data that links inequity being discriminated against to health disease outcomes are less robust. And so going forward, this is one of the areas I think that needs more attention. The topic of early, the model of what happens at -9 to 3, to age 3, -9 months to age 3 is a critical one. And we now, sort of like, I like to joke and say, well, Freud was right, at least for this, right? And so early childhood development is so critical. And understanding what that does to not the kid at age 8, autism or attention deficit disorder, but what happens to the adult at age 40 as a consequence of that experience. And I think, how do you do that? Nobody has 40-year cohorts, right, that studied this. So this is, I think, a really important area. There are a couple of efforts at NIH that you should know about. One is the ECHO study, the rescue of the National Children's Study. Matt Gilman, who used to be at Harvard, is running that. They've brought together, I think, a total sample size of close to 50,000 kids, or recruited as kids. These are retrospective cohorts. They've given out the awards. They have a coordinating center. And it's about, I think, close to half of the kids of this participants are minorities. And the oldest cohort is recruited in early 1980s, so they're now young adults, or close to 30. And then there's some newborns. And I think they're going to try to create an infrastructure, data structure that people then can do either analysis from or ancillary studies. They're building it. They just started last year. So this is an important area. We're supporting ECHO, and we're actively talking to Matt to look for opportunities in that. There's also the ABCD study that's funded by NIDA primarily, and also alcohol, but we are also supporting it. It's a prospective cohort study of adolescents, but actually starts at age 10. Because it's NIDA, it's heavy on imaging of the brain. But it's collecting a ton of data, and it's not available yet because they just started recruitment in September of last year. But this is going to be ongoing for at least the next decade. They're recruiting 10,000 10-year-olds and propose to follow them for 10 years. Again, looking primarily, the outcomes there are going to be more related to substance use as well as mental health. But I think it'll be a very rich data set to be able to look at. People have heard this getting under your skin. I think the basic scientists, biologists really resonate with this idea as something that speaks to them in terms of what they're looking at in a very mechanistic way. The intergenerational transmission of social disadvantage, I'm still trying to understand this myself, but staff have been teaching me about it. And then identifying SES, race stressors that better predict biological changes, and there are a number of studies that have tried to focus on that. A couple of recent things that came through my email or desk. This is from the Jackson Heart Study that we fund, and I don't think it came out of this group, but maybe it did. You'll tell me if it did. And it's looking at, are we missing people for lipid-lowering therapy? I'm not convinced that this is the right message, but it did look at whether your coronary artery calcium score was greater than 0, which is overly sensitive. You have detectable coronary calcium, doesn't mean you're going to ever get coronary disease. But if it's 0, you're good. That's good. No coronary calcium is good. But 600 is bad, but not. So I don't know what to do with this. And they looked at incident events people over 0 versus 0, and applying American Heart Association and task force guidelines, they showed different rates, and they calculated that you missed African Americans if you used a task force not eligible for statin, who had a coronary artery calcium score that was above 0. And then, you know, my take from this, without getting into too much detail, and I didn't read the paper cover to cover, but looking it over, are we trying to medicalize normality too much? All right, now that's time. 10 minutes to stop. For real. This came out of this center. This is from MESA, a great cohort study, looking at, again, a mediator. We know that left ventricular mass predicts heart failure. We also know that African Americans are more likely to get heart failure, and they have a differential effect on their cardiovascular health that affects left ventricle function more than it does the pipes, the coronary arteries. And we don't know why that, we don't understand all the reasons why that is. This is trying to link air pollution, measured particulate matter, nitrous oxide, to this, and showed some association of increase in LV mass compared to whites among blacks. No other effects by social factors or other. MESA includes Chinese and Mexicans, I think, right, Anna?
Yes,
yeah, okay.
there are some other Latinos in the,
a few other, you know, Cubans and.
Small number of Cubans.
And
Caribbean.
so again, differential effects of pollution by race, and understanding, you know, making observations from these kinds of studies then helps us try to figure out, well, what's the mechanism. We go back and try to look at some other questions that you can look in more controlled environments. I think this is the last slide, and this is an old slide, or next to the last slide. This is community SES and 11-year mortality rates. Irene Yen published this with George Kaplan back in 1999. And I think it was the beginning of the population, the importance of place in looking at mortality. This is the Alameda population study. So the lowest SES community, you can see high income and low income have similar mortality. In the low SES, so use a community metric of SES and then compare individual households. And as you move the gradient to the highest community SES, the high income people do better, low income people do worse. So I've always been intrigued by this observation. So poor people in a high income neighborhood really do worse. And it may help understand some of the global health findings that we see, where you go to a place, everyone's poor, or there are a few people, of course, who aren't, and there is a gradient in being poor, but it's different than being poor in upper west side, or whatever it is, upper east side of Manhattan, where everybody's a lot of people are wealthy. So this is from Tom Leviste. Again, interesting study in population health. It's work in progress. I don't think they've published on this. He's looking at segregated, integrated neighborhoods by income stratification. I think it's New York where he's looking at Brooklyn. Low income neighborhood, segregated liquor stores off the roof, through the roof in terms of the concentration. In the high income neighborhoods, it's there, but it's not as marked. And Tom is very interested in this phenomena. What's happening in some of our urban societies, like where I live now in the district, where Brooklyn or other places that are really diverse and are, you know, quote unquote integrated in terms of you don't have a 90% from one group living in this neighborhood. So again, an area of, so I just finished with the framework just to leave it at that, and then hopefully we have time for conversation. So thank you very much for your attention.
Thank you. That was great. Covered a lot of ground in the 10 minutes you had.
Thanks for the extension.
I think we do have some time for questions.
Good.
This was wonderful to hear the breadth of the vision, Eliseo, and also the data. I think that it's so nice to see the big picture data as part of the discussion. I think that's terrific. Knowing this group, I think we should sit down to take questions,
okay,
because they're going to ask questions. So
I'm glad to
we're
sit.
open.
They don't need to use the mic, right? I can just repeat the question
I
for the
think
video.
so, yeah. Go ahead. Yeah, go ahead, Alex, stand up, and maybe people should just introduce themselves just to...
Sure. So I'm Alex Ortega from Drexel University. Nice presentation. I have a question about, you mentioned in your talk about wanting more R01 proposals to NIMHD now that you have the parent grant. So I just spent 5 years on an HDEP, the Health Disparities Equity Promotion Study Section, which is now reviewing the parent grant R01s. The last time I was there, I think our workload was like 120, 130 applications, which was a lot for our study section. So what are the plans for NIMHD in terms of study sections, developing? I know for a period the study sections came out of CSR. Now I think it looks like you guys are going back to CSR. And not just for the parent R01s, but also the center grant proposals, which I believe were reviewed at NIMHD. Is there going to be more partnering with CSR? Right. What's the plan?
So questions about study section process. So things that we set aside money for, like the centers or the research centers for resource centers for minority institutions, research centers, or some grants are reviewed internally. So, well, not internally. We pick the review committee as ad hoc, and they just do that. So yes, the centers of excellence are going to be reviewed the same way, not by CSR. They help us, but we do it. When we put out a program announcement, we have the option of saying, let the grants come into the main one and see what happens, versus creating a special emphasis panel where we review them and we pick the special emphasis panel. Program scientists are always lobbying for special emphasis panels because they think these ideas are going to get killed in the normal study process. And at least with a special emphasis panel, we'll get a better review, a more fair review, and we'll be able to have something to fund. It's hard for me to know exactly. I don't want to get too in the weeds of those decisions. I let them decide on these aspects. But you are right that it is an issue. There's a global issue of review. I think reviewers tend to get hung up on details. What I like to say is they're great at seeing the leaves and even the branches, but they fail to see the trees and the forest. And sometimes they get too picky on stuff. And it's 3 people setting the tone, and everyone votes. So there's no arbiter. Now the arbiter is on our end, so if a grant gets scored, we can always have a discussion internally about whether we think this is a high priority area that we're going to fund. We don't go strictly by score. I've discussed with CSR about the option of creating another review committee to absorb hopefully the more R01s that we're going to see, particularly those that are multidisciplinary focused. So we have one that's the one that you were on. So creating another one that's more looking at the interfaces between behavior and biology, more population science, perhaps more clinical research. But in order to get there, I have to show that we have a problem. And so we're still in the data generating. We need more applications to be able to do that, unfortunately. But for the special announcements, we usually do get some variance of special considerations. Does that help?
Yeah.
Okay.
I think I jotted down names of people who I think should apply to each of these things. So I'm going to go after you. You know this already.
Good,
so,
good. That's what deans do.
So I think there's a lot of opportunity here. I think a lot of the areas that Eliseo laid out are areas in which a lot of people here are working very specifically. So I think it's a real opportunity for us to really, start to get good proposals in to NIH and to NIMHD. So.
I'll let her call.
Go ahead, Darryl. Then we'll go to name.
Darryl Brown, Drexel University. And the slides you put up on the diabetes related ESRD struck me because I teach a class in health inequality. And again, the composition probably 75% white students, okay? I put up a slide like yours that shows that decrease in mortality or incidence of ESRD-related diabetes. And then that one line shows that whites have gone up like 54%.
28%.
20%.
Yeah,
What do I call that? You said I can't call it a disparity because it's not a disadvantaged population.
Well, it could be. That's poor whites. We just don't have the granularity on the data. It's still lower than any other group as a global group. But because we have not systematically collected some SES metric as well as we have collected race ethnicity in this country over the years, I think it makes it hard. So if we broke that down by level of education, would that help? Or household income, or even imputed household income. That might show that the reason that's gone up is because of poor people and not because of anything having to do with race. So, or access. In order to get that result, you need medical care because you already have a disease that we know has a natural history of progression. Diabetes-related kidney disease. Once it's established, you leave it alone, you end up on dialysis over time. And we know that we can do things to delay that, to slow that slope down. And I think that's what we saw is people getting access to that care and seeing improvements in those metrics. So.
Tanae?
Sure. Tanae Lewis, Emory University, and I have a broader question, more NIH question, broader NIH question. So the data that you presented on the Ginther report, and I think particularly the underrepresentation of minority scholars, in particular with respect to our ones, is troubling, and has been troubling for years. And I think, and of course this is anecdotal, I haven't gotten a sense. I've heard minority scholars come and present these data, but I don't hear a lot about the Ginther report from other people in institute directors, division directors, and so on. And I don't have a clear sense of how people feel about that. And I know, so I've been fortunate enough to be funded, but I get funded the third and the fourth percentile, not on the bubble. And I have colleagues who get funded above the pay line using select pay, they're white. I have colleagues that get funded doing HIV research at the 30th percentile. And I'm just curious why select pay isn't being used to address some of these issues, or who's concerned about the Ginther?
So that's a big question. So how do we incorporate this whole concern about diversity? So I can just say that as an institute director, I just took it on as a personal mission that this is important to speak up. That's what I did at UCSF as a professor and a division chief. And there is, though, some people who feel like they want to be very hesitant about it. I had an African-American department chair who was very hesitant to make this an issue, personally. It took him a while to do it, much less than the prior chair who was white Jewish, who from the get-go said, we need to do something about this. So I think sometimes a lot of individual dynamics play. There are 3 other institute directors who are African-American. At least 2 of the 3 are very active in this space in terms of working with Hannah Valentine and addressing the issue, at least internally. I don't know if they go out and say these things to their constituents the way I do, but I can understand that National Heart, Lung, Blood's got a lot of stakeholders, a lot of things to address, and so Gary Gibbons may reflect it differently. Hannah Valentine was recruited to be Chief Scientific Diversity Officer at NIH by Francis Collins. And her role is to make this an issue, and she has a seat at the table in the director. So it is something we're doing. Now, you mentioned some specific things about select pay, and this is something to translate that. So when you get your grants scored, the notion I used to have was, okay, if you score above the pay line or below the pay line, that's when you get funded. And new investigators, early stage investigators get 3 or 4 bonus points. So they get funded the first time. This is only true for research grants, so R1s basically. R21's another story. How do we get more diversity if people are getting systematically scored worse, or there's bias, or the areas are not, low success, etc. And yes, one of the mechanisms is to use this. So what I'd say 60% of the institutes now don't use a pay line. They may publish one based on where they funded that year, but they're not strictly adhering to a pay line. We're calling it pay zone. So, and what's happening is that we have data that shows that a score is not fully predictive of outcome. So if a grant scores, in the 15th percentile, or gets a 15, an impact score, really outstanding, versus a 25, 5 years later, you don't see any difference in those PIs. They're all both equally successful in terms of where they're publishing, the discovery, and the science of what they're doing. And the data show that internally. We've looked at this data. So that tells you that it's all kind of, it's not such an absolute thing. So at NIMHD, we have the luxury or the efficiency of having few grants. So we can actually go over all the grants that are scored and decide, we want to fund this or we don't want to fund this on the basis of program scientists' assessment of the grant. And now if they score in the 3rd percentile, that's a pretty strong predictor that you'll get funding. Versus if you score in the 30th, if you get a 30 percentile. But the 30 is not an automatic no way category in our case. And I know the other institutes are using more of that. Now, they may not have the flexibility to go to 35 or 30 even, but they are using more in that zone, in that intermediate area, and going select pay or sort of skipping grants. So we're not funding in order of score. And that's an acknowledgement that review committees don't always get it right. And number one. And number two is some people are really good at writing grants and get really good scores. But the science may not be so compelling or so interesting or so important of what the institute really or the field needs. And people who take risks, who are into new areas, are often more harshly criticized. And a score that may not look as great for them may actually be as good as you can get with the way the review system works. And so we think more of it as a factor and not a final grade. Let's put it that way. Does that help?
It does, but I guess what I'm wondering is if we have, in your slide you talked about unpopular topics.
Right.
And I think if unpopular topics are more likely to be proposed by minority researchers.
Low success topics.
Low
Yeah,
success
thank you,
topics.
yeah.
I think the top is the exact phrase. I think that could be a place for a program to intervene.
Right.
And of course this is all anecdotal, but I don't get the sense that that's where a program intervenes.
Right. Well,
So that's what I'm asking. Like that could be.
what?
a place.
That's what.
Yeah.
Those are all the NIMHD topics. So yeah, we definitely intervene. I can't speak for the other institutes. I think they would love to see us, do more R1s like we're planning to do, and sort of push the envelope on this, so that they are also pushed on this. We're also undergoing, we cannot, let's put it this way, we cannot explicitly use individual characteristics of the investigator in making funding decisions. So, when people review grants, the race ethnicity disclosure of the applicant is not linked, is in a separate database. We look at this for other reasons. But we can definitely use that as a factor, and I know for a fact that other institute directors have done this when they're deciding on which grant to fund. A factor, you're still, what's the science, what's the topic, is it a priority for us? And where does it stand in that regards? All of these are combined. And I think the novelty of saying, well, we're going to use this as a factor is something that, I don't know, 10 years ago, people were completely not comfortable with. And is it still a smaller number of directors? I think most of them are pretty sympathetic. But they all have their own way of dealing with these things, so I can't speak for them.
One quick thing, in terms of this low success topic here, I think that's a really important area to focus on because, I think what's happening from my experience on study section, I chaired Keynote for a few years, was that these kinds of topics, and this is already a mixed study section, this is pretty typical. So there were geneticists, there were some clinical people, not a lot, and some epidemiologists. And what happened is with these applications, when the purely genetic applications came in, only the geneticists really talked about them. Everybody else couldn't understand what the hell they were talking about. With all due respect to my genetics, I've learned a little bit now, but sometimes they would explain, and everybody said, oh, well, that doesn't make any sense at all, or yeah, that sounds great. But most of the time, people didn't understand because it was highly jargony and technical. But the other applications, the ones that were about discrimination, or the ones that everybody could comment, because everybody said, oh, I can talk about this.
Right.
And so it created a different kind of dynamic in the study section, and I suspect that really affected the scores of these applications.
Yeah, I think.
Because there was a lot of evaluation that was not really that rigorous.
Right.
So I think taking a look at that.
No, it definitely, you're right, low success topics is an issue, and we need to address that. There's a big issue on reproducibility now, percolating through basic science. So a lot of experiments that people are doing are not reproducible. And why is that? And so that's been a factor. So, basic scientists only recently have started to use statisticians. Hey, I reviewed basic science grants for, I don't know, some committee I was on at one point years ago at UCLA for a different, it wasn't NIH. And I go, well, they don't do any calculations of how they're going to be able to detect a difference. They just pick 50 animals here, 50 animals there, and they. So, I mean, there are some things that we take for granted that they don't know how to do. Or the T32 programs, the training programs. John Lorsch, who directs the National Institute of General Medical Sciences, is really after some standardization of what kind of training postdocs are getting. Because there's no, it varies from place to place, lab to lab. And I sat there and, well, don't they all get like some basic coursework and methods? And they go, no, they don't do it. So the stuff that population and clinical scientists and social behavioral scientists have been used to doing is new. So it's not all groovy for them. They do have issues. But there's a lot more basic scientists than there are population or clinical scientists. And even at NIMHD, there's basic scientists who are recycled into different, so that's part of the challenge as well. We think some of that is networking, mentoring, so people are not sort of tuned into the right network to know, and getting grants really looked at and tuned, but it's a challenge. What Hannah is really trying, with finding all these results, she's doing some interventions to see if we can make a difference. And so the diversity of the scientific workforce is an ongoing priority that is getting attention at NIH. I feel very comfortable in guaranteeing that that's not going away right now anyway, under this leadership. And there's a lot of support for that.
I think we'll have 2 more questions, and then we'll have to go to break. Go ahead.
Cleo Caldwell. I forgot to introduce myself when I was up there before. But I have a quick question that relates to this whole idea of when we talk about health disparities research, one of the things that we hear a lot is there's an interest now in more interventions in terms of what we can do.
Right.
And we know when we're talking R01s, one of the things you must have is pilot data.
Right.
I'm hearing more and more, though, that R34s, and I just got an email a couple of days ago that some institutes are also getting rid of R21s.
Mm-hmm.
So what's going to be the mechanism to allow researchers, especially young investigators, to get this pilot data if these mechanisms are disappearing?
Right. So pilot grants from centers like this, diversity supplements, underutilized opportunity. R21s are kind of like fool's gold, you know. If you get one, it's great. It should be a good starter grant, and it'd be great for secondary data analysis. But the way institutes have interpreted them and the way investigators have used them, it has a much lower success rate than R01s, actually.
It's harder than an R01.
Yes, exactly.
If you're doing intervention research.
Well,
so
doing
that's
intervention
what I'm
research,
really
you
doing.
can build, you know, it's hard to do an R01 where you say, well, I'm going to do the pilot data in part of the R01. It's really,
Right, that
you know, those
doesn't
days
work.
are gone.
Right.
So you need to figure out why what you're proposing has a reasonable chance of being successful. And I think what can you do with a cap of $500,000 on an R01? It's either an efficacy trial, proof of concept, mechanism, you know, to see whether this process variable that we know is related to the outcome that we're really interested in works. And more of the big intervention studies are being done on a much larger scale. So it becomes so that's, I think, the other issue. Do we really know enough to do an intervention? The other thing that I think that is very important is to do empirical. Picori has used these. If you have a very large data set, you know, natural history studies using this, you know, time series before and after design, which is very methodologically weaker, but if you have a lot of observations, it can be a very powerful way of seeing whether something that was done to intervene makes a difference. And people have done this particularly in public health science, but also in clinical science. So.
We'll take one more question. Go ahead.
Daryl Gaskin at Johns Hopkins. So your question sort of was a foreshadowing of my question, because I was thinking about the R34s in terms of trying to develop interventions that address problems in minority populations. And I and some colleagues of mine, we have a project, and we looked and we were thinking about this institute, your institute, and realized that you didn't fund R34s, and so we decided to go someplace else. But is there any plan on the horizon to do this?
Yeah.
And let me just, my second question, since you did mention about sort of collaborating across institutes, and so is there anything that sort of we can, as researchers, do up front to sort of, if there's something in which your institute would be interested in say, NIMHD or NIA, that we can do up front to sort of develop projects that could leverage funds across institutes?
So keep in mind that we are small. And we have had pre-allocated commitments that are required by legislation. So whereas, I don't know, let's say 70 to 80% of other institutes' budgets are allocated to RPGs, or R01s predominantly, but other research grants, ours has been closer to 30%. And I don't say we need to be at 80, but we need to be higher. So getting distraction with other, I think R34s are sort of before a clinical trial, can you show that you can actually do this? Which is great, because that way you don't invest in the trial unless you demonstrate you can do it, or you have some process outcomes that are making a difference. When you submit a grant, you pick the institute that it goes to. And you then also have the option to put a secondary institute. So that's one way to get us into the picture. If a grant gets scored and it looks like it's on the bubble and the institute is not sure that they're going to fund it, program scientist really likes it, they start shopping it around. They talk among each other. And I've gotten emails and say, oh, would you be interested in this? And even directly to me from people I know at NIA, for example. But they usually happens at a different level, and then grants that maybe are encouraging, but they say, well, we're not really going to be able to fund it, then other institutes will pick it up. Now, sometimes it's because it's too expensive, or they don't think that's quite there, and we may say we don't think it's for us either, or we may endorse it. So that goes on all the time. So it's usually as a secondary assignment, it's a possibility. And we actually are just going to probably fund with heart, lung, and blood, like 20% of an R1.
So should we have that kind of conversation with project officers?
Yes. Before you submit or after it's been reviewed. You can't really do it in between. But before you submit, you should actually
Shop it around.
talk to program officers as much as your time allows. That's part of their job. And after it's been reviewed, also actively talk to them. In fact, for young investigators in the room or new, it's a resource. These are trained scientists, and they're not just administrators. They need to know the field. And bouncing ideas off them, having them tell you about opportunities or process issues are all things that you should take advantage of. I know I didn't do enough of it when I was in that situation as an assistant professor, but that's part of their job, and so do take advantage of it.
Okay, I think we have to wrap up, but we'll continue this conversation as part of a panel that we have after the break, and so please join me in thanking
Thank you,
Eliseo
Anna.
once again.
Thank you.